Today we close out the fall semester of the Neuroscience and Public Policy Seminar. And our speaker is Richard Brown, known as Rich to his friends. And I was admonished via the program coordinator, via Rich, to be brief. But brevity is not one of my strong suits, but I will do my best. There are very few people who can say that they were educated at a university that bears their name. Rich was, because he has a bachelor's degree from Brown University. In a remarkably short time, 3 years later, he got an MD degree from Brown University, and then went to the University of Washington, where he earned a master's degree in public health. He spent a few years at Jefferson Medical College on the faculty, and he came to the UW in the Department of Family Medicine in 1990. And now he's a tenured faculty member in the Department of Family Medicine. Now, one of the best and shortest ways to evaluate the stature of any university professor is to try to determine how many times they have been invited to make presentations, because if people want to hear what you have to say, you probably have something important to say. And Rich has made 194 presentations at national and international meetings, and another more than 100 for regional meetings. So he's clearly one of the go-to people in the country, if not the world, for consultations and lectures, etc., on alcohol and substance abuse. He also leads the medical students in trying to do these evaluations, teaching them how to make those evaluations. And he has made enormous progress in trying to help people understand what needs to be done if you're going to treat people who are dealing with problems with alcohol or drugs. And as I think you all know, addiction is a huge problem in our country, and we need more Rich Browns to try to lift us out of the pit that addiction has put our country in. What he's going to talk about today is a very long title, so I'm going to ask you to read it, but it makes very, very good sense that you try to intervene when people are having problems, you try to intervene behaviorally and screen, and then do something about the problem. And I think what Rich is going to tell us is something we need to pay very careful attention to if any of us expects to go out and help people who are struggling with drugs or alcohol. Rich?
Thank you all for your warm welcome on this cold Friday afternoon. Thank you, Ron, especially for your nice introduction and for inviting me to be here with you today. Yeah, I'm excited for the opportunity to spread the word on what I like to call BSI, Behavioral Screening and Intervention. And honestly, I have to say I was a little intimidated to be invited to speak about this at a meeting where neuroscience is discussed. Because I think especially in this country, but elsewhere, we tend to put a lot of stock, a lot of hope, a lot of dreams that there will always be that high-tech scientific solution right on the horizon. And certainly there have been wonderful advances in addiction and other aspects of medicine involving neuroscience. But what I'm going to talk about today actually maybe is more in the soft science realm. So, maybe neuroscience is somewhere around here, so maybe your status isn't quite as high as chemists and physicists or mathematicians, but I'm even farther down the chain, I don't know, psychologists and really a lot of health services research. That's not even on the map here. So, but I am glad to be talking about you, because what soft science has accomplished is actually figuring out how we could quadruple one-year quit rates for smokers, the leading cause of death in our country and around the world. We figured out how we can reduce binge drinking to the point where we get a 1/3 reduction in injuries and an even greater reduction in hospital admissions. And we also figured out, by a lot of soft science, how we can dramatically improve one-year remission rates from depression. But before I go any farther, I do need to disclose that I do have a conflict of interest. I'm the CEO of a company that helps clinics deliver these services, but I assure you I will try and give a very evidence-based presentation, which will hopefully be unbiased. So here's really the nature of the problem. Across, I'll just focus on the US, but clearly other countries have similar issues, that more than 40% of our deaths and most chronic disease in this country can be traced back to unhealthy behaviors or behavioral conditions. And so it really behooves us to get a handle on how could we systematically intervene in these issues to dramatically improve public health. And when we think about improving our healthcare system, inevitably we're also talking about decreasing costs. Patients with chronic disease are the largest consumers of healthcare. So, gee, if we can get a handle on these behavioral risks and disorders, we could have a huge impact on improving health and decreasing costs. So let me jump back ahead now. And I do want to put this in the context of the triple aim. Anybody who's involved in healthcare policy or leading healthcare organizations is now being driven by this mantra that we have to figure out how to improve health outcomes for our population and have healthcare do a better job at improving health outcomes rather than just delivering services that may or may not improve outcomes. We have to enhance the experience so patients, although nobody likes being sick, I don't know anybody who loves going to the doctor, but we would do a better job with patients if they actually appreciated the experience more. What could we do to change that experience? And we want to control costs. So in that context, when most people look at this data here, these data, we see 1 in 5 of us smoke, more than 1 in 4 of us in our state binge drink at least once a month, 8% are using drugs, 8% are depressed. But wow, look at the whopping prevalence of us who don't get enough fruits and vegetables, don't get enough exercise, and increasing numbers of us are obese, more than 1 in 4 right now. So when most people see this, they are attracted to this side of the chart here, and so many of the headlines about health these days do focus on obesity. But unfortunately, there's not as much that we can do about these issues. Science has not progressed as far as we need to on these issues. It is true that brief advice can increase fruit and vegetable intake for some people, but unfortunately not very many. Unfortunately, just brief interventions in primary care settings for healthy very people rarely actually get those people exercising as experts recommend. And even treatment for obesity is very modest in its outcomes. The best studies show that on average we can help people sustain weight loss of 10 to 15 pounds, which is not trivial. It is enough to reduce blood pressure, blood sugar, and cholesterol by a few points, but unfortunately none of these interventions has translated yet, as best we can tell, into significant improvements in cardiovascular and other health outcomes. And none of the data suggests that any of those interventions would actually be useful in reducing costs of care. So maybe someday we will get there. But in contrast, on the other side of this slide, we have lots of data that behavioral screening and intervention is very effective for tobacco and alcohol. There's increasing evidence for effectiveness for drugs, and certainly a lot of evidence that we could be helping depress patients more by screening and intervention as well. So that's really what this talk will focus on, is on what soft science has already taught us about how to improve care for these behavioral issues and therefore improve health outcomes in general. So as I mentioned, tobacco use is the leading cause of death in our country and most countries around the world. I'm sure you've heard about all the risks that tobacco poses for health. I won't belabor those. I'll dwell a little bit more on alcohol and drug-related health concerns because I think most people know a bit less about those. But clearly anybody who's drinking too much, and I'll come back and define that soon, how much is too much, and anybody who's using illicit drugs or misusing potentially addictive prescription medications such as pain relievers, which is more and more common these days, are at higher risk for all of these really tragic health issues, cause a lot of suffering. Individuals who are just drinking too much are at higher risk for all of these problems. And a lot of people don't realize that drinking too much alcohol can raise blood pressure, raise cholesterol, and contribute to heart disease. It is true that having just one when a woman has just one standard drink in a day, When men have just 1 or 2 standard drinks a day, they decrease their risk for heart disease. But when people consume more than that, we actually increase the risk of heart disease beyond the risk for abstinent people. And then a lot of people don't realize that excessive alcohol consumption can contribute to cancers as well. 11% of breast cancers, for example, among women are related to their alcohol consumption. And perhaps if more women knew that, we'd have fewer women engaging in such risky drinking. And then we have a bunch of conditions where maybe if alcohol didn't cause them, if people are drinking excessively, it's much more difficult to treat these conditions. Treatment tends to be less effective. So another reason why we ought to be systematically figuring out who among our patients is drinking in this risky way, and is there something we can do about that? And then, of course, there's a whole bunch of other tragedies that people are much more likely to face in their lives if they're drinking excessively or using drugs. So, example, lots of crime at least involves alcohol and drugs. Most people involved with our justice system either have an alcohol or drug problem or were intoxicated at the time of their crime. You see lots more suicides, falls, etc. So many tragedies are linked with alcohol and drugs in our families and in our communities. Now, I also mentioned the importance of our need to decrease healthcare costs. And who are the folks in our country who are paying most for healthcare? Well, they are employers. And studies show that for every employee who smokes, employers lose out on more than $3,700 a year. About half of that is because of higher healthcare costs. Half is because of worse productivity. For every employee who is depressed, employers lose out on more than $3,000 a year. Again, a mix of healthcare and productivity costs. And for every employee who drinks excessively, we see double the healthcare cost and triple the workplace injuries. So these behavioral issues have huge impacts in the workplace, and it's really hard for employers to recognize them. Often they'll recognize the people with the severe problems, but they don't recognize people with a lot of the hidden problems who are contributing dramatically to costs. And just to help dispel some of the stereotypes, national population data tells us that 3/4 of all the binge drinking adults in our country are employed, as are 2/3 of drug users. So this is not just a problem among unemployed patients, patients with Medicaid, patients without insurance. This is a problem among all segments of our population. Here's a particularly tragic set of data on the prevalence of alcohol and drug disorders in Wisconsin and how many people are getting help. So first of all, if everybody across our state actually did undergo an alcohol and drug assessment, we would likely find that about 7% of us actually have an alcohol problem, 2% of us have a drug problem. But the real tragedy is look at the very low proportion of people with these disorders, active disorders, who have gotten help in the last year. And some people unfortunately say, well, maybe they got help last year. But let's face it, do we ever say that about a diabetic or an asthmatic? Well, you got help last year for your problem. We're not going to help you this year. Of course, people with active problems need ongoing help. And unfortunately, it's sad commentary that we do a little better with drugs, not much better, but a little better, because most of those people are getting help when they're involved with the justice system. If we did a better job in the healthcare system, we could maybe help people avoid some of those justice problems. Now I want to focus on some data from the public sector, and this data focuses on dual eligibles. So those are individuals who are insured by Medicare and Medicaid. Most of those individuals are below age 65 but disabled in some way, but some are over age 65 and low income, and some have chronic kidney disease. And researchers were curious of all of these dual eligibles with one of these chronic diseases, high blood pressure, diabetes, coronary heart disease, congestive heart failure, chronic lung disease. They were curious how many of patients with these diseases also have a mental health disorder, an alcohol or drug disorder, or both. And the reason this is of particular interest is that these dual eligible patients tend to be responsible for a very large segment of healthcare costs relative to their proportion in our population. So the researchers had access to claims data across the country. So basically all the insurance claims that get submitted to Medicaid and Medicare were analyzed. And it's important to recognize going into this is that we often underdiagnose mental health and alcohol and drug conditions. So if anything, this data will understate their prevalence. But here's what they found, that among patients with these 5 chronic diseases, only a quarter to a third had no claim submitted, no diagnosis of a mental health or alcohol drug disorder. About half had a diagnosed mental health disorder. Another several percentage had a diagnosed alcohol or drug disorder. And another 10 or 20% had both diagnosed. So often we are trying to do a better job helping patients get their blood pressure down, their blood sugars down, reduce risks for cardiovascular disease, better treat cardiovascular disease, lung disease. We're so focused just on addressing those issues, and it often doesn't occur to us, oh, well, if this patient has a mental health problem, an alcohol or drug problem, maybe that's why they're not managing their disease as well at home. We need to get a better handle on the mental health and alcohol and drug issues if we're going to do a better job managing these chronic illnesses. And this has tremendous impact. So one impact we see is on hospitalization rates. And hospitalization is actually the largest cost in our healthcare system. We're all striving to figure out how can we reduce admissions to hospitals. So you can see now folks with these diagnoses with no mental health or alcohol or drug disorder, they have on average less than 1 hospital admission per year per patient. Okay, so that's pretty good. But with a mental health disorder, more hospitalizations, alcohol and drug disorder, even more, and both way more. Okay? And the vast majority of these hospitalizations are not psychiatric hospitalizations. They're not admissions to drug and alcohol treatment programs. They are general hospitalizations targeted at getting these diseases under control. So we see 3 to 6 times the rate of hospitalizations with mental health and alcohol and drug problems. So lots more suffering from these diseases and lots more healthcare costs. And here are the costs. So those who with one of these illnesses without a mental health or alcohol or drug problem, average total cost of healthcare per person in a year ranges from $8,000 to $16,000. But with mental health problems, it's more, similar to alcohol and drugs, and with both, it's quite a bit higher. 2 to 4 times the total cost of care. So often people think about behavioral screening and intervention as a way to intervene early with behavioral issues to prevent chronic illnesses, but it can also be important actually in helping us better treat patients who already have chronic illnesses and elicit better health outcomes for them, prolong life. So I could give you reams of more data, but let me just stop there, and I hope you're getting the sense that our healthcare settings are really flooded with patients with these issues. They're very clinically important, they dictate a lot of health outcomes, and they're very economically important. They're responsible for much higher healthcare costs. So that's the problem, and often when I give a talk like this, I can sense that people in the audience are starting to get depressed, that, oh my God, what can we do about all this? But there is a potential solution called behavioral screening and intervention, or BSI. So here's what BSI involves. First of all, we screen everybody, typically once a year. And by screening, that involves asking people maybe 1 or 2 questions on each of those behavioral issues. If people answer the questions in a way that shows low risk, we just reassure them, reinforce their good, healthy behaviors. If they answer the screening questions in a way that suggests a possible risk or problem, then we ask them some additional questions, and there's actually been 30 years of research on what are the best questions to ask for these various topics, questions that tend to elicit the most accurate information. And so occasionally the assessment is negative, and that's because the screen gave us a false positive result, so we reassure those folks. The vast majority of people who are positive on that screen fall into an intermediate risk category. So they are not people who need referrals to mental health specialists or alcohol and drug treatment programs. They can be managed right there in the primary care clinic, the emergency department, or the hospital bed. And that's the real strength of behavioral screening and intervention, is to catch people early when people don't need expensive care, when they don't have to accept referrals that often bring a lot of stigma, and therefore, unfortunately, few patients actually going for such services. But occasionally we do identify those patients with high-risk severe disorders such as alcoholism, drug addiction, major depression, and certainly we want to try and refer those folks for specialty-based care. There's another strain of research I won't talk more about today, but it's showing that if we can bring that kind of specialty care into primary care settings, so let's bring the alcohol counselor to the family doctor's office, let's bring the psychiatrist, the mental health counselor, we're much more able to get patients to partake of those services. So that's certainly a trend we're going to see more of over the next few years. And then, of course, once we've administered the intervention or referral, we need to check back and see how are these services working. Are people getting what they need, or do people need more or different services? So BSI is not rocket science. It just makes total sense to screen people systematically. For those who screen positive, figure out how much risk or problem they have, and then administer appropriate services and see if we're making headway as we hope. So clearly, if we do this, we more systematically identify people earlier in the continuum of disorder. We therefore help them avoid complications. We prevent their behavioral condition from getting worse. For example, we can probably prevent a lot of binge drinkers to progress to having significant negative health and social consequences. We can help prevent a lot of alcoholism if we can help intervene early and get people to drink less. So we'd also save a lot of money, not just for alcohol treatment, drug treatment, mental health services, but we would also avoid a lot of the medical consequences, hospitalizations, et cetera. So how does this work? Well, through WIFL, the Wisconsin Initiative to Promote Healthy Lifestyles, we've worked with 44 clinics across the state to help them administer these services. And what we've learned from that experience is this is the kind of workflow that works best. So the first step is to have a receptionist be triggered, typically by an electronic medical record system, that a patient has not completed a screening questionnaire in the last year, and ask them to do so in the waiting area. Only takes a few minutes. Then the medical assistant, who typically checks vital signs, checks the patient in, brings them to the exam room, can take a quick look at the questionnaire. And if there are any positive responses, the key to effective BSI is that there is someone else added to the healthcare team. We call them a health educator, it could be a health coach, prevention specialist, whatever you want to call them. Somebody who is specifically dedicated to working with these patients with positive screens. And the reason that's important is that we've learned from 20 years of experience, I don't know why it took us so long, that physicians, nurses, and other staff just don't have time. And if you think about it, with the prevalence of all these issues, if a physician actually tried to spend only 5 minutes on each of those issues as they occurred in the normal workday, a typical family doctor would need to extend his or her workday by more than 2 hours. So that's just not going to happen. We have to expand the healthcare team if we're going to have the workforce there to actually respond to patients and administer evidence-based interventions. In emergency rooms and hospitals, it's even easier. We just send health educators around to meet with patients, introduce themselves, and deliver the services. So what do we train these health educators to do? And that's part of our program that we provide training for these health educators who are then hired by these clinics and hospitals. So one thing we teach them is to help promote commitment to change through motivational interviewing. Okay, can we help patients find reason to quit smoking, to reduce their drinking? Because the typical doctor just saying, hey, you better cut that out, tends not to be effective. So motivational interviewing actually has been studied now for over 20 years, and it avoids these common pitfalls. I know before I learned motivational interviewing, I found myself just giving people lots of advice and information. You know, I kind of assumed I'd go to medical school, I'd learn all this stuff, I'd pass it on to patients, they'd be healthier, they'd appreciate it. Well, it didn't work that way. Advice and information rarely by itself changes behaviors. Scare tactics tend not to work either. They just kind of make patients more agitated, and often they kind of doubt what we're predicting for them, and most of the time, fortunately, they're correct, that they're not going to die, you know, as soon as we think. Twisting people's arms, coercion, shaming, none of that works. And in fact, studies show that patients who we often think are in denial and resistance are actually only reacting to the way we are talking with them about these behaviors. If people get a sense that we're judging them, we're impatient with them, you know, we think we should be able to control them, they naturally tend to clam up. And so instead, motivational interviewing takes a much more warm, empathic, respectful, collaborative approach. And first of all, we see what patients are interested in learning about these risks. We help focus on risks and consequences that they think are important rather than ones that the doctor or nurse thinks are important. We help them weigh the pros and cons of their current behavior or changing their behavior in light of what's important to them in their lives. And often it's not only health. Maybe there are other goals they have that for the time being are more important than their health, and maybe that's why they're willing to make a change. So by all means, let's ride with that. So we help them make the best decisions for themselves, and when we do that, we find patients are much more likely to implement and sustain change when they feel they've owned the decision, they own the process, rather than the doctor telling them what to do. So there's actually over 1,200 studies now in the peer-reviewed medical literature suggesting that motivational interviewing is really the way to go to promote a variety or changes in a variety of health-related behaviors. So our health educators are very well trained there. And if anybody's interested, by the way, this is the most important thing I've ever learned about healthcare. So here are a couple of books and also a website that you can go to learn more about this. Well, once those patients are committed to make some changes, then our health educators learn to work with them around designing and optimizing change plans. And this comes out of various realms of psychology, cognitive behavioral therapy, relapse prevention, and alcohol and drug treatment. And so we help patients set limits or targets about their behaviors. How many days a week am I going to allow myself to drink? How many drinks will I allow myself on each of those days? And this applies to smoking, exercise, any behavior you can think of. What might trigger you to go beyond your limits or not meet your targets? How could you avoid those triggers or better manage them? What other activities can you engage in so you're less apt to exceed your limits? How can you change your environment? Medications can be very helpful for people who are alcohol dependent, opioid dependent, or smoking tobacco regularly. Social supports. Are there people they can lean on? Maybe it's friends or family members, or maybe it's something more formal, classes, actual therapy. Can people set rewards for themselves? So if they stick with their plan for a certain amount of time, they can give themselves some positive reinforcement. And many of you probably know the brain is actually wired, so positive reinforcement is actually more influential than negative reinforcement. And contingency plans. What might somebody do in that moment when they're about to exceed their limits or not reach their targets? Call a friend, go for a walk, take a bath, something like that to kind of get them away from that behavioral temptation and give them time to get back in the mindset of their change plan. And then all-important follow-up. When can I meet with you next and talk more about this? They also deliver collaborative care for depression. And I give talks about this to many audiences, and I'm amazed how few people in healthcare know about collaborative care because there is so much data behind its effectiveness. So this also involves expanding the healthcare team with a couple of people. That all-important health educator is measuring the severity of depression. So the brief assessment is typically a PHQ-9. There's been a lot of research showing the validity of that questionnaire for assessing the severity of depression symptoms. Once we know that, it gives us an idea about what kinds of treatment might be helpful. These health educators can spend way more time than I could as a busy family doctor educating patients about depression, instilling optimism. They can do behavioral activation, actually promote behaviors that by themselves can often help decrease depressive symptoms. So get patients exercising more, engaging in helpful behaviors to promote sleep, scheduling fun in their lives, socializing, eating healthier. And for your depressed patients who sometimes are also anxious, some relaxation exercises. So we typically can engage patients in 1, 2, or 3 of those behaviors, and that seems to be very helpful. They can also spend more time negotiating any obstacles to referrals for medications and counseling. And they tend to contact patients proactively every 1 to 4 weeks, depending on the severity of their symptoms, and check in about whether there's barriers to taking their medication, going to counseling, and so forth, and help them get around those barriers. And they re-administer that PHQ-9 periodically to see how well is the treatment plan working. Studies show that when PHQ-9 scores drop less than 5 points per month, that's an indication that consideration needs to be given to changing the treatment plan. So they serve as a bit of an alarm box puller when maybe the physician is not using this kind of objective means about gauging decreases in symptoms. And then there's a psychiatrist who we've learned it's often not necessary for them to see the patient to get full benefit. If a psychiatrist can be overseeing care, reading the medical records with patient's consent, of course, and they can advise family doctors like me on diagnosis and treatment because obviously most psychiatrists know more about treating depression than most family doctors. So that in and of itself can increase the quality of care, especially with regard to prescribing. There's just so many different medications to choose from, and it's pretty complex often to choose the best one. So there's actually 69 randomized controlled trials where a random half of depressed patients just got usual care, a random half also got collaborative care, where collaborative care clearly is superior. And there's now starting to be studies that show that collaborative care can also be helpful for other mental health disorders. And it's really just adding that health educator and getting some psychiatric oversight. And as I mentioned, the health educators are well equipped to make referrals to other resources. They have a nice list of all the referral resources in their communities, separated out by health insurance, locations, special services, etc. And they offer that all-important follow-up. Is whatever the patient's getting working well? So that's what BSI is all about. And now let me tell you about some of the research that's been done to demonstrate effectiveness. So first of all, this is taken from the current federal guideline on tobacco cessation, which advises all healthcare professionals around the country what we ought to be doing for our patients who use tobacco, especially those who smoke. And the meta-analysis in that document tells us that when clinics are not conducting screening, about 3% of smokers tend to quit for a year starting soon after a clinic visit. So that's basically the baseline quit rate, people who were going to quit anyway without any help. But if we do screen and we offer some assistance, presumably, we double the quit rate to 6%. But look what we can do to quit rates when we offer optimal intervention services. And remember, this is the leading preventable cause of death in our country. And I'm still amazed how well our healthcare system is set up so that if people have heart attacks, strokes, lung cancer, we are ready to spend tens, hundreds of thousands of dollars to help those people, and that's great. We all want that to be there, but we are so poorly set up to help people quit smoking and avoid so many of those health catastrophes. So here's what optimal intervention is all about. It basically requires up to 5 hours of one-on-one counseling over more than 8 visits. And when I give this talk to a lot of healthcare people, they say, oh my God, that's a lot of time. But wait a second, this is the leading cause of preventable death. And if you think about it, how much assistance does it take to help somebody who's addicted to alcohol or drugs? Way more than this. And it stands to reason that people who are addicted to nicotine are going to need some ongoing support. It's a tough addiction to beat. In fact, I've treated many patients who have recovered from their alcohol, cocaine, heroin, methamphetamine addictions, but they still couldn't quit smoking. So of course, patients need some ongoing support, and I've asked audiences of healthcare professionals, I've not had one say, yes, we deliver optimal interventions. Very tragic. It's also good news that non-physicians can do just as well delivering this kind of support as physicians can. So it doesn't have to be the expensive physician. It can be that less expensive, more cost-effective health educator. And patients do best if they get medication and counseling, so there is a role for the physician or nurse practitioner or physician assistant there. Okay, so that's one way that BSI could dramatically improve health. Another way is by addressing alcohol. Let me give you some other concepts before we talk about effectiveness of BSI. One concept, now I'm finally getting to, is how much drinking is too much. And actually there's been hundreds of studies that have shown us that in terms of standard drinks, 12 ounces of beer, 5 ounces of wine, 1.5 ounces of 80 proof liquor, all has the same amount of alcohol. In terms of those standard drinks, hundreds of studies are very clear that when men have more than 4 on an occasion, women have more than 3 on an occasion, we start to see negative health and social consequences. And I've given a talk on this in many other locations where they say, oh my God, that's a lot of alcohol. In Wisconsin, I hear much more frequently, what? That's so little. Don't most people drink like that? We clearly have a very predominant risky or binge drinking culture in our state. There's also studies that demonstrate when men have more than 14 standard drinks in a week or women have more than 7, we start to see, and this is a persistent pattern, we start to see more chronic disease related to alcohol. Okay? So, and a lot of people get a little confounded. You know, often we're not talking about alcohol just in terms of health. We're talking about it in terms of moral judgments and so forth. So I want to be clear, this is not a moral issue. This is just an issue of health and safety, just like we try and help maximize health in patients by keeping their blood pressure, their cholesterol, their blood sugars normal. I think we should spend equal attention helping them keep their drinking in a safe range as well. And it's important to recognize there's a continuum of drinking, so it's not just alcoholics versus non-alcoholics. So there's low-risk drinking, there's higher-risk drinking that I've just defined, then drinking can eventually cause repeated negative health and social consequences, and there may also be that disruption of the pleasure-reward center in the brain, which causes basically these symptoms of dependence or addiction. So in WIFL, with our project to help 44 clinics screen all their patients for these issues and intervene, we found that across the state, about 3% of primary care patients seem to be alcohol dependent. And they would clearly do best if we could get them to specialty-based treatment. But look at this, 9 times that many patients are in these other high-risk or problem categories. And the good news is they have normal pleasure-reward centers. They don't have terrible urges and cravings to drink. At least as far as their pleasure-reward system goes, it's easier for them to be in control of their drinking. So, and because they are so much more numerous than alcoholics, they actually cause most harm in workplaces and communities in our state and around the country. Yet, because they have normal pleasure-reward centers, they are the low-hanging fruit. They are people who we can just talk to and maybe promote commitment to change, and they can very quickly say, yes, I'll quit or I'll cut down, and they can do that. So across our state, the data shows 27% of our adults would benefit from these brief interventions. That's a lot of people. And the National Business Group on Health reviewed over 50 randomized controlled trials, and here's what they found about the effectiveness of brief interventions. For these patients, we would reduce emergency room visits by 20%, injuries requiring medical attention by 1/3, hospital admissions by more than 1/3, arrests and car crashes by about 50%. Could you imagine multiplying these benefits across more than 1/4 of our adult population in every community? Wow. And the science is there. We know we can do this. We are just not doing it. It's a shame. And I already mentioned about collaborative care, those 69 randomized controlled trials. I want to share some more data with you that comes from Project Next Door in Minnesota, Project Diamond. They've been most successful about getting collaborative care into primary care clinics because they were able to strike an arrangement with their healthcare purchasers and payers that these services would be reimbursed. So what they found is patients who get just usual care for depression, a family doctor like me doing the best I can with my 15-minute visits, we see 34% of depressed patients with a 50% reduction in their PHQ-9 score a year later. With collaborative care, we can double that. And how many patients are in complete remission 1 year later? 30% with usual care, but over 50% with collaborative care. So we know how we could be doing so much better treating depression. But unfortunately, we're not doing it. And there are cost savings also. Remember that triple aim. Part of what we need to do is save money in healthcare. A very nicely done randomized controlled trial right here in Wisconsin, published in JAMA by a colleague of mine about 12 years ago, found that for every primary care patient who screens positive and then gets a brief intervention for their risky drinking, we reduce healthcare costs by over $500 in the next year. And that study just assessed cost savings from emergency room visits and hospital admissions. If they had looked at pharmaceuticals, outpatient visits, physical therapy, et cetera, I think we would have seen more savings. So for every dollar spent delivering this service, we save $4 within 1 year. Can you imagine going to a bank and say, I'll give you $1 today if you give me $4 next year? We're lucky if we get an extra 4 cents these days, right? And then another study in Washington State focused on disabled Medicaid patients. They had a real good database to look back on there. And they found that these services decreased total cost of care for these patients compared to similar individuals who did not get these services by about $4,400 over the next year. Spectacular healthcare savings. For depression, the best study shows that collaborative care, typically lasting 6 to 8 months while people get better from their depression, costs us about $900 up front, but over the next 4 years we save over $5,000 in healthcare costs. For tobacco, it's really hard to do studies to fully elucidate the cost savings, because most of the savings will come 5, 10 years later, even longer, where we are avoiding all sorts of heart attacks, strokes, cancer, lung disease, and so forth. But experts believe the return on investment for tobacco services is even greater, just takes longer to play out. We pulled together a bunch of peer-reviewed literature, looked not only at healthcare cost savings, but improvements in productivity, decreases in absenteeism, et cetera. Excuse me. And we found that in Wisconsin, employers would save close to $900 for every patient who gets screened. And then if appropriate, they get additional intervention services. So that's caught employers' ears in our state, and I'll come back to how that's influenced some of our policy initiatives. Nationally, this is just a handful of the dozens of national organizations that recommend that BSI should be routine in all healthcare settings. You're certainly familiar with the CDC. The National Business Group on Health advises employers how to get the best bang for their buck for their healthcare dollar. You're certainly familiar with NIH. This is the Drug Czar's office. The Alliance and Business Healthcare Group are two employer healthcare purchasing collaboratives. The Alliance is based right here in Madison. Business Healthcare Group is in Milwaukee. And we also have Wisconsin Manufacturers and Commerce agreeing that our business environment would be more competitive if BSI would help reduce some of the economic burden of these issues on employers. The Medical Society, the umbrella organization for our community health centers in our state, so many people agree this ought to be routine in health care. And in fact, the U.S. Preventive Services Task Force, the folks who primary care physicians look to most for recommendations on preventive services, agree that all Americans ought to be getting these screening and intervention services. Then another group came along, the National Commission on Prevention Priorities. They were asked to answer the question, which of all the preventive services out there recommended by this group actually would give us the best bang for the buck? And they were focused not just on behavioral issues, but cancer prevention, cardiovascular prevention, et cetera. And they found that these tobacco and alcohol screening services actually have more impact on health and better impact reducing healthcare costs than screening for cancers, cholesterol, blood pressure, diabetes, all adult immunizations. So there's so many services which if we did not get from our regular primary care physician, we would think it's malpractice, yet these services actually are even more effective and would save more money. So I mentioned WIFL. We've been fortunate enough to be funded consistently from various federal agencies since 2006 to help spread these services around. I've mentioned the 44 clinics. We've helped deliver these services to lots of patients. One nice result from our evaluation is that we find that patients are very satisfied to receive these services. And this is a question that often gets raised when we're trying to spread these services. Are patients really willing to talk about these sensitive issues in these clinics and emergency departments? And the answer is a clear yes. And part of that is because we make sure that health educators who are hired to administer these services are warm, empathic, respectful, non-judgmental. But the other part is they're very valuable training on motivational interviewing, which avoids arguments, it avoids twisting arms. So even patients who decide not to change their behaviors for now tend to rate the services very highly. And we've demonstrated outcomes, behavioral change outcomes, basically akin to what we see in prior randomized controlled trials. But that's a real accomplishment for us because in those randomized controlled trials, people are specially selected and volunteer to participate, whereas our health educators are serving basically whoever walks into the clinic that day. So this is a slide I like to show folks when I'm trying to spread the word. So there's so many reasons to deliver BSI. In summary, patients and communities would benefit. We'd have better health, stronger families. If we can successfully intervene for a parent who is drinking too much or is depressed, we're certainly going to create a better environment for children to grow up in, less crime and violence, safer highways. For healthcare providers, certainly they would like to do a better job preventing and treating chronic illness, and this would help. We can reduce the burden for providers. There's a health educator now down the hall who can take care of this, so you can focus on other things. And then there's a bunch of inside baseball kinds of reasons why this would actually be selfishly beneficial for healthcare settings. If healthcare settings can meet patient-centered medical home criteria, Basically, they will qualify for higher reimbursement rates across the board by many insurance companies. And so BSI would help them meet dozens of those criteria. There's more and more ways that healthcare settings have to show that they're providing high quality care, meeting certain quality measures. For example, what proportion of patients who should have gotten mammograms did get a mammogram. So there's more and more quality measures that BSI can help improve outcomes on. Perhaps you've heard of accountable care organizations. These are vertically integrated healthcare organizations. There's at least one hospital. There's primary care clinics, there's specialty clinics, and then there's other services where the ACOs either have internally or contract for physical therapy, occupational therapy, mental health, alcohol, and drugs. And once you've formed an ACO and you commit to take care of a certain number of Medicare patients, your first obligation is to meet 33 quality measures, which BSI can help you do. And then once you're doing that, then the folks at Medicare nationally will review your cost data compared to cost data for similar patients, and for every dollar that they realize you've saved in taking care of those patients, the ACO gets to keep at least half of that. So wow, all of a sudden there's incentive not for healthcare settings just to provide more services to generate fee-for-service payment, but there's now strong incentive to provide high-quality care and save healthcare costs at the same time. And BSI would certainly fit the bill there. And there's lots of ways we would help hospitals as well. Medicare is actually reducing reimbursement for hospitals with high rates of readmission, patients who are admitted and come back again within 30 days. So BSI can get at the risk factors there. Hospitals are required increasingly to report what are their success rates for surgeries. And there are several studies that show if we can get patients to quit smoking or reduce their risky drinking several weeks before surgery, we can improve surgical outcomes. Okay, so there's lots of selfish reasons for healthcare settings to do this as well. And then I've mentioned employers would certainly benefit for all these reasons. Our local and state governments would benefit tremendously. They are large employers, and there would be reduced burden on all these services. So lots and lots of reasons why this would seem to make sense, especially if we're trying to meet this triple aim. And I like to assert that this is the biggest leap clinics and hospitals can take toward the triple aim, and so far nobody's argued with me about that. So I think of this as a no-brainer. I hope that's not an insult to anybody here at a neuroscience conference. But, so now let's get to, well, why aren't these services being delivered, and what have we done and what can we do about that? Well, I was fortunate to be able to spend quite a bit of time agitating about this during our initial grant. And one thing we realized we needed to do was define effective reimbursement. So part of it is just to have a billing code, because whenever you bill a health insurer for a service, there has to be a code number to go with it. So there has to be a code for all of these things. And there were new codes developed several years back. But the fine print in the health insurance plan's reimbursement policy is key. So they have to be willing to reimburse when the service is delivered by a health educator, because the doctors and nurses don't have time. They need to be willing to reimburse when the health educator provides a service during the same day as when a physician provides a service, because patients are not going to make separate appointments just to come in for BSI. And there has to be no out-of-pocket expenses by patients. If patients have to pay a little extra, as we've learned, they just say, oh no, I'm fine, I can do without that. So they save a few dollars, but the system loses an opportunity to save lots more money. So we were successful, actually. We were able to convince Wisconsin Medicaid to start reimbursing for these kinds of alcohol and drug services. And we also were able then to document effective reimbursement from 13 commercial payers who were willing to follow Medicaid. So we were very proud of that. So from that, we were able to create some spreadsheets, and we could show clinics how if you hire a health educator, you could actually generate a small profit delivering these services. So we thought we had the battle won. But here's what happened. Only 10 of our 18 clinics who were with us at the end of our first grant actually kept their health educator on when they had to start paying the salary. And after that, there was very little uptake at other clinics. Our next grant allowed us to recruit other clinics, but we could not pay health educator salaries. Those clinics had to pay the health educator salaries themselves, and we would provide all sorts of training and support. But we couldn't fill even half of our slots statewide for that project, only 8 clinics. Very disappointing. So we thought we could just line up reimbursement, demonstrate small profit potential didn't work. We realized that fee-for-service reimbursement is necessary but not sufficient, that the potential small profit was really small potatoes. By itself, it was not going to carry the day. And we also realized that primary care settings truly are overwhelmed reacting to other changes. They're trying to install electronic medical records, make them work better, adjust to meaningful use criteria, so you have to really be using your electronic medical record field so that you can actually look for data rather than just put information in narratives. You have to generate the infrastructure that allows you to report these quality measures and then keep doing better and better on those measures. And then there's just the daily stresses and strains of a complicated operation. So next, in that second grant we had from the Agency for Healthcare Research and Quality, where we tried to recruit clinics to do this, but only got 8, we had some funding that we could actually commit to an organization that in Wisconsin is actually responsible for developing a lot of quality measures. So we said, hey, let's get on the quality measure bandwagon. And so they agreed, and we had their funding lined up. But a lot of that organization's membership actually was healthcare provider organizations. And they said, we are up to our ears with current quality measures. We don't want new quality measures. And since they are the members of this organization, they carried a lot of weight. So that didn't work either. So now what we are doing is we are working with purchasers. And my wife, who is in business, kind of sat down and reviewed Sales 101 with me and said, well, who is in the most pain and has the most to gain from BSI? And at first I thought it was the health insurance companies, because don't they want to save money? But in reality, they're kind of middlemen. They're kind of pass-throughs. You know, healthcare costs go up. They just pass on the premiums to people who are buying the healthcare. So it's really the people who are purchasing the healthcare that are hurting the most from these annual increases. And in fact, over time, the more something costs, the more of a cut the middlemen get to take, right? So we decided it's time to go to the healthcare purchasers. So we worked on this for years, and actually now we've really engaged these 4 organizations, these 2 employer healthcare purchasing groups, ETF, the folks responsible for healthcare benefits for state employees. Forward Health is a brand name of Wisconsin Medicaid. And they called a meeting of healthcare purchasers in July. And healthcare purchasers tend to listen because these folks are responsible for paying the bills for 1.5 million people in our state. That's quite a few. And so they got a bunch of healthcare provider representatives in a room and basically said, hey, we really wanted to get you thinking about this. They were so energized by that meeting, they actually got a grant, so now they're hiring a person representing all 4 of these groups that's going to go around the state and basically say, healthcare providers, we really want you to do this. Here's how we would benefit. Here's how you would benefit. If there are barriers, please let us know what they are. We'll work with you to fix the barriers and make this happen. So that's what we are trying to do now. We're the only state in the country who's gotten as far as we have, and other states are looking to us to see if this purchaser-based approach is going to carry the day. So in summary, the research is clear. BSI would truly be a win for everyone, especially us as patients. Behavioral risks and disorders are very common among us. They cost us all dearly in terms of suffering and economically. Hundreds of studies, separate studies, tobacco, alcohol, drugs, depression, have shown that BSI is effective. What we at WIFL have done is to put all these BSI services in one package and show that it's logistically and even financially feasible to deliver these services in busy healthcare settings. There's clear research that this would prevent chronic disease, it would improve outcomes for current chronic disease, and this would benefit just about everybody you can think of, and truly would be the biggest leap toward that triple aim. So that's where we are now, and thanks for the opportunity to fill you in. I'm glad to take some questions.